Welcome to part 2 of the Clinical Documentation Improvement Series titled How to Document Effectively for Command, Control, Metrics, and Fully Informed Care. My name is Glenn Krause. I'm the Executive Director of the Foundation for Physician Documentation Integrity. Let's jump right into our polling question. What is the primary challenge for physicians in accomplishing effective clinical documentation? Well, actually, if you go back and look at these answers, the correct answer is obviously unclear of required content. This is a big challenge for most physicians when I go out and talk to physicians and enter into discussion. What needs to be in the chart is almost information overload. And it's really a simple process of documentation, which I'm going to go through. What is effective and complete documentation? Well, basically, it's reporting accurately and giving a good indication of what's going on with the patient. And it really means less documentation, not more. Some key concepts to consider is when you're documenting your H&P, we just need to know how sick the patient is, what is the provisional diagnosis. Of course, we need a physical exam, congruent with your clinical judgment and patient's presentation. And we want to show versus tell, how sick is the patient. We want to describe the patient's presentation with an accurate history of present illness and have a relationship to the assessment and plan versus generalizing and just use on specific terms, abdominal pain, chest pain, CHF without further qualification, diabetes with not documenting type 1 or type 2 or uncontrolled. And really what we want to see is, why am I seeing the patient? What is the nature of the presenting problem? What are the other current clinical relevant patient problems that you want to include in your problem list, as well as your assessment and a plan that's congruent with your assessment? So assessment, where am I? Proper diagnoses with specificity, acute on chronic renal failure with the stage 1, 2, 3, 4, 5, or end stage. And the plan is, where am I going? Where am I going with this patient? What are the fundamentals of documentation? Well, we want to have a strong history and physical. We want to have a problem list that's updated in the format of a problem-oriented medical record. When we have our progress notes, we want to have our assessment congruent with the plan, only to list the diagnoses that are clinically relevant that you're managing or have an impact on the patient's presentation and your medical decision-making, and we want to have a complete and accurate discharge summary. Rather than the electronic health records guiding our documentation, we really need to be able to take command of our documentation. And how do we do that? Well, we want to capture and accurately report our clinical judgment, analytical skills, thought processes, and problem-solving ability through specificity and documentation. As I mentioned earlier, we wanted a good, strong account of the patient's history of present illness and relationship to the extent of the physical exam. We also want to have a formulation of a problem list and what are initial plans of care. We want to have an update of the problem list, current versus resolved. We don't want to be necessarily including any past problems. If they're certainly past histories, they don't necessarily need to be in a problem list. If they're resolved, please document resolved. And when we're talking about a progress note, this is a big challenge that needs to be addressed with documentation. I caution you against cut and paste and carry forwards. The Office of Inspector General, in their work plan for the last 2 years, plus Medicare administrative contractors, which is the contractors who process our claims, are looking very closely at non-succinct, cut and paste, cloned records. Be very careful about that. We need a clear picture of the patient's clinical status. In your progress notes, we want to see, rather than documenting pneumonia 5 days in a row, include in the assessment whether the pneumonia is improving. So aspiration pneumonia slowly improving. Tell us why. What is your supporting criteria? Whether the chest x-ray is slowly clearing, the patient is breathing better, white count is trending down, very important. We want to be able to show the patient's severity of illness through our history of present illness and proper documentation of the acuity of specificity and diagnosis. It needs to match your thought processes and your tests that are ordered, which comes from your plan of care and your complexity of medical decision-making. Assessment, as I mentioned earlier, let's include all the clinical problems. If the problem has resolved, we don't need to include that diagnosis to save some time. And in your conclusionary statements, what is the clinical rationale? How did you come up with the diagnosis of sepsis? Is it in regards to the patient's indwelling Foley with a E. coli in the urine? And when you order diagnostic test, here's a key point. order your diagnostic test, link the symptom or the disease process that's guiding your ordering of the test. And I mentioned earlier specificity in diagnosis. And now let's take a look at our plan of care. In our plan of care, we want to have a diagnostic workup necessary, which is congruent with our problem list. So every time we have a plan update, let's have a diagnosis that is associated with. And the therapeutic plan, why am I ordering this IV antibiotic, and so forth. In our progress note, I encourage you to use the SOAP note format. It guides our thinking and keeps our notes succinct. As I mentioned earlier, let's avoid cut and paste. Each note should be unique, with an updated or interval history of what are the patient's complaints. Is the chest pain improving? Is the abdominal pain improving? And what scale are you using? Your progress note should indicate a demonstration of the clinical stability. Is the pneumonia improving, worsening? Is there any new diagnosis that you're dealing with? Or is there a change in diagnosis from if it's chronic stable systolic heart failure and the patient went into fluid overload in the form of acute on chronic systolic heart failure? Important to know. Update your problem list with those new diagnoses, and any changes or additions in plans of care, please include those as well. Referring back to statements such as see orders is not sufficient to show the acuity and where you're going. What is the most important element of a progress note to demonstrate the need for continued stay in the hospital? The correct answer, while all three are important, is the assessment. That is the most important element of your progress note. It shows your clinical judgment, your thought processes, and how is the patient responding. What's the acuity? Very important. Please spend the time with your assessment to give us your thoughts and how is the patient doing, what are the diagnoses, any new diagnosis, and so forth. And remember, clinical specificity. Command of documentation is instrumental in reporting proper metrics because the data is massaged through ICD-9 codes and risk adjustment is done. And if you have good documentation reflecting the severity of your patient, that translates into the quality of care reporting, what makes the metrics accurate for your care. In your final progress note and discharge summary, we want to have an overview and recap of the admission, which includes what were the presenting signs and symptoms, any objective clinical information from the beginning of your history and physical, all diagnoses that occasioned the admission or impacted your medical decision-making, and of the primary and any secondary diagnosis. What is your plan of care and what was the course of treatment? And what are your future plans for care, including continued care, and updating your problems on the problem list to reflect the active problems and the resolved problems as well. If you include all these elements in your discharge summary, all the information necessary to properly code the chart to reflect your medical decision-making and your acuity of the patient will be addressed. The proper codes will be assigned, ICD-9 transitioning to ICD-10 in October of 2015, and the outcomes will be assured from the standpoint of efficiency, effectiveness, and the metrics that are going to be used to judge the value of your care. This concludes part 2 of the clinical documentation series from Quante MD. Thank you for listening.